Thank you so much. So again, welcome to this Evidence Library event. It's really great to see so many of you. This event is part of our Evidence Library series, which gives you the chance to ask your own questions of leading academics talking about the latest research in important criminal justice topics. I'm going to be handing over shortly to Professor Charlie Brooker and Dr. Coral Sirdifield, who will be running through a presentation based on their Evidence Library review. I'll then be asking a couple of questions to them before I hand over to you in the audience to ask any questions that you have. That Q&A section will be chaired by Russell Webster, who's been working with Clinks in producing these evidence briefings. He'll be leading on that section. So if you do have any questions for Charlie and Coral as we go through, please post them in the chat and Russell will be collating them and bringing them together for when we move on to that section of the agenda. So Paul, if you can pop a link to the Evidence Library review that we're going to be looking at today. I'm really delighted that we'll be joined by Professor Charlie Brooker, who is an honorary professor at Royal Holloway University. He's interested in mental illness across the criminal justice system, especially prison and probation. He published as a joint editor with Coral the first book on mental health and probation entitled Probation, Mental Health and the Criminal Justice System. He then jointly edited a special mental health edition of the European Journal of Probation with Coral in 2022 to 23. And Dr. Coral Sirdifield is a senior research associate at the University of Lincoln. She has an interest in understanding and improving the health of people in criminal justice and has published extensively in this area. Her most recent work includes testing an approach to measuring the health and social care needs of people on probation and developing standards and quality indicators to support health improvement amongst people on probation and measure the quality of care that they receive. So thanks so much for joining us this afternoon, and over to you, Charlie and Coral.
Thank you. Have you got our slides ready, please, Paul? Maybe that's a no.
Paul, are you able to bring up the slides for us? Bear with us, everybody.
There we go. Brilliant. Thank you. So welcome, everybody. Am I going to be able to control these slides, or do I need to do the next slide, please?
You'll need to say to Paul to move on when you're ready. For.
Next slide then, please, Paul. Okay, so we thought we'd start the presentation today just by providing a bit of background on the prevalence of mental illness amongst people on probation, as kind of background to why we think this topic is important. So what you can see on the slide here is findings from a study that Charlie and I conducted some time ago now, looking at the prevalence of mental health disorders amongst people on probation in Lincolnshire, using a stratified random sample. And to do this, we interviewed 173 people using a selection of validated screening tools. And as you can see, overall, we found that 39% had a current mental illness. And then you can see the breakdown of the different types of disorder there. So 18% had a mood disorder, 27% anxiety disorder, 11% psychotic disorder, and 5% eating disorders. And around about half had a past or lifetime mental illness. And then 72% of those with a current mental illness also had problematic drug or alcohol use. And 89% of those with a current mental illness also had personality disorder. So I think the main sort of takeaway message from this is that a large proportion of the probation caseload will have a current mental illness. So this is something that probation practitioners are working with day in and day out, and that dual diagnosis is the norm rather than the exception. So when we're thinking about service provision, we need services that are able to work for people that have a mental illness and a substance misuse problem. Next slide, please. So when we looked at drug misuse using a tool called the DAST, the results indicated that just over 12% had a substantial or a severe level of drug abuse. Next slide, please. And we looked at alcohol misuse using something called the audit tool, which is a gold standard tool for this. And we found that just over half, 55%, scored A+, which indicates a hazardous level of alcohol consumption. And what's interesting here is that we can compare that to a general population study, where we can see that it's around about 20% in the general population versus that 55% amongst people on probation. Next slide, please. We also looked at personality disorder using a tool called the SAPAS to screen for likely personality disorder cases. And we found a prevalence of 47% amongst people on probation, and that compares to just under 14% in the general population. So quite a difference there. Next slide, please. We also looked at people's contact with mental health services, and despite kind of the high prevalence figures that I've just run through, we found quite low levels of contact with mental health services. And the one that probably stands out the most here to me is psychotic disorder, because only half of that population reported any kind of contact with mental health services. Next slide, please. Also in way of background, I wanted to talk about the MPS health and social care strategy. I think policy is slowly starting to recognise the importance of looking at and working with mental health disorder across the criminal justice system, and the value of that in terms of things like rehabilitation work and reducing reoffending. And one really good example of this was the MPS health and social care strategy, which is probably the clearest, most up-to-date, really, articulation of probation's role in relation to working with people with mental illness. And you can see here, it outlines several different roles for probation staff, including signposting, improving pathways into services, supporting use of mental health treatment requirements, aiming to inform local commissioning processes, and increasing training for staff. Next slide, please. This is you now, Charlie.
Yes. So to be able to signpost, or indeed to refer on to a pathway for someone that you know has a mental health problem, you really need to know something about mental health, I think. And I've just flagged up here the communality between the MPS strategy and the Council of Europe's recent white paper on mental health in prisons and probation, which reinforces, I guess, what Coral's just been saying about the English strategy. The staff's role in the recognition of mental health disorders and providing interventions, facilitating access to mental health should be defined, thereby allowing the design of appropriate training. And we do know that there is very little mental health training in the preparation of probation. Next slide, please. We looked at this across Europe with the backing of CEP, which is a Europe-wide organisation fostering probation practice. They funded this small study, which used the mental health literacy scale to just examine exactly how much probation staff across Europe actually knew about mental health. So the 35 items with a multiple choice. It wasn't just knowledge, it was also looking at attitudes to help seeking, and it has got high discriminant validity, and it's been used in a lot of studies across the world. So it goes that. Next slide, please. Here are some of the scores. You can see the range at the top is 35 is the lowest you can score, 160 is the highest. And probation staff across Europe scored on average 129. You might think that's not bad, you know, it's getting on towards the 160. But if you look down the table, you'll see that that's the same score as the general population in Portugal. It's a lower score than students in Australia, and it's a lower score than Christian clergy in the United States. Not terribly high in context, I don't think. Next slide, please. what's really important about knowing something about mental illness when you're working in the probation field, I think, is that, as this slide shows, the more you know, the higher your knowledge and attitudes to mental illness, the greater the confidence you feel in working with people who have a mental illness. And those two scores are highly correlated, as that graph shows. Next slide, please. Again, this is going back to our prevalence study, but it's worth highlighting here. This is a sub-study that we did in the probation study, looking at the actual case records of probation staff and relating that to the diagnosis we determined through the study. And 73% of mood disorder was identified, nearly half of current anxiety disorder, a much smaller proportion of psychotic disorder, which, like Coral alluded to earlier, I find particularly worrying, any likely PD, but very good on recognising drug problems and alcohol problems, which I guess, you know, given the treatment requirements, isn't surprising. So high on depression, high on drugs, high on alcohol, and a very poor recognition, I think, of psychosis. Next slide, please. Just to say something about suicide, because this is an important feature of the probation population. Unlike many countries, England has kept very good data on the number of suicides committed, not permitted, the suicides that have occurred in probation over the last 20, 30 years. And these are the latest figures that have been reported in research. You'll see that the annual suicide rate for men is 18.8, and for men on probation, it's 105. So that's an increase of a factor of about 5. Yeah? But for women, the contrast is absolutely staggering. It's 5 in the general population per 100,000, 146 in the probation population. So that is really a serious concern. Next slide, please. And this is when those suicides occur. And as you can see, as you go from left to right on the graph, the bulk are in the first few weeks after discharge from prison, release from prison, and there's a diminishing tail all the way down to the first year since release. There's a very important study by Binswanger who looked at people coming out of a New York jail in the first 2 weeks after release. And she showed that death rates 12 times higher than the general population in the group leaving prison. Next slide, please. Sorry, this is I'm racing through this because I know we haven't got much time. Coral?
Yeah. So given that background, we conducted some systematic review work to look at what the international literature tells us about the most effective approaches to improving health outcomes for people on probation. So you can see this involved reviews around mental health, substance misuse and suicide prevention, and you can see the links to the different papers there if you want to look at this in detail. But just briefly, I would say that overall, this probably points to the lack of research in this area, disappointingly, more than anything. But one thing that it did flag up was quite a well-researched and evidenced approach that's used in the US in the form of specialist probation officers. And we're happy to tell you more about that later after the presentation, if that's of interest. Next slide, please.
This is our examination. This presentation is about the best evidence. This is our examination of all the mental health initiatives that have been in and around probation over the last 10 years, I'd say. And what evidence can be gleaned. And of course, whilst worldwide it would be a different picture, it's just now reported in England and Wales. There have been some studies looking at the mental health outcomes who've offended and been given a mental health treatment requirement. As far as we know, we can't find any external evaluation of ATRs and DRRs. Robinson and Domine did some evaluation of RARs back in 2019, but don't think there's ever been a full-scale evaluation. Quite a large evaluation of liaison and diversion by Disley, 2016-2021 from the RAND Corporation. Reconnect and Enhance Reconnect have only recently been commissioned by NIHR, so there's no evaluation report on that. They haven't been commissioned by they've been commissioned by NHS England as services, but NIHR have let recent contracts on the evaluation of those contracts. Little evaluation of the role of forensic psychology in probation. There's an initiative currently being discussed to look at commissioning mental health expertise into approved premises, but that's just being planned at the moment. No external evaluation, as we understand, has been commissioned on health and justice coordinators, a new role in the probation service and hopefully an important role in the future. And Moran reported an evaluation of the offender PD pathway, which included probation, but that reported or tried to undertake field work in the middle of the COVID crisis, and there's not very much substance in that report because of it. So I wouldn't say, looking at that lot as a group, that the evidence was very strong. Any of the policy initiatives that we've seen launched in the last 10, 15 years. Next slide, please.
Okay, so ultimately, people on probation are in the community, and we need to make sure that there are appropriate services in the community to be able to meet their needs. So I've been leading a piece of work, which Charlie's also worked on recently, to develop standards and quality indicators for use in probation, linked strongly to the role set out within probation health and social care strategy. And the idea is that these would improve the evidence base and also serve as a platform from which we could do quality improvement work, which would then ultimately lead to improvements in care and then health outcomes for people on probation. That's the hope. So I'll just briefly run through this. So next slide, please. So to create those standards and quality indicators, we firstly looked at the literature to look at, are there any other standards and indicators out there in use in other adult criminal justice settings that could be relevant to that role within probation. We also did an expert panel survey, which went out to people in criminal justice and health roles across the field. And then working with Revolving Doors, we also sought lived experience views through a focus group. And for both the experts and the lived experience panel, we basically asked them, what are the characteristics of high quality care for people on probation within that role set out for probation? So what does high quality care look like? Next slide, please. And within that, and I should say this is broader than mental health, but nevertheless, I think it's relevant. We found 11 characteristics that you can see listed here. And I've put a few of them in bold there for you, because I thought they were maybe particularly fitting for the mental health presentation that we're doing today. Next slide, please. And what we'd like to do now is go for some funding to be able to pilot the use of these within probation. Next slide, please.
Well, what we can see in conclusion is the prevalence of mental illness is higher, much higher than the general population. The presentation is the norm, not the exception. Service provision should reflect this. And, therefore, as Coral's just been alluding to in the last few slides about the recent project on commissioning, data is needed on mental health needs to inform commissioning decisions. We think that what we're planning to do will help commissioners in terms of providing that evidence. Of course, it would need to be done on a much larger scale than just one service. There is still a massive evidence gap around people with a serious mental illness on probation and their access to services. But I think what we can say about that, as Coral's also, is that, I mean, even to the point where there are randomized controlled trials looking at probation services in the United States, there is a much better evidence base for that than anything else that we've seen. It's worth noting on this that the lead researcher probably in this field, a woman called Tonya Van Dent, will be giving a talk in a webinar hosted by the INCJ in May in 2020, later this year. And that's going to be the precursor to a wider debate about what to do for people with serious mental illness on probation in services across the world, actually, obviously not just in England. It's really interesting, actually. There is a specialist mental health probation service on a very small scale in one state, in Germany, in Europe, and that's the closest we get to it on the whole of the continent. And one of the people who works in that service will be part of the roundtable discussion at the webinar. We have ideas about content for training on mental health and how that should ideally be developed alongside people with lived experience in the voluntary sector. We think we've got a good place to start with that. Wouldn't by any means argue it's the finished article. The problem is always going to be, you know, once people have obtained their basic qualification, like, you know, work as a promotion, how are you going to make that training available in a meaningful way to people who are doing a really difficult, busy job with high caseloads, and give them time out of the service to do that? How might we improve things in the future? Is there a role for mental health clinics in probation? There are one or two mental health trusts in England, actually, who introduce community mental health nurses into probation and offer clinics on not a huge basis, but it is done. But that's not as a result of a national plan. That's as a result of a local ad hoc initiative on the part of the mental health trust. You know, I don't think that on its own is good enough. And as we've said, work is underway on introducing that model into approved premises. We'll just leave you with the last slide. We're not going to speak to it, but it's our link back to what we believe includes. So I'll give you a chance to look through that.
Thank you so much, Charlie. Thank you, Coral. That was really, really interesting sort of context to the evidence library review that you put together. I'm going to sort of throw a question back from what you were just speaking about, Charlie, before we move on to questions from the floor in a second. But you reference in the review the current challenges, and you just mentioned it there, around high caseload sizes for many probation practitioners, which we know can be a barrier for many of those best practice recommendations that you just referred to in that last slide and that you referred to in the review. And you've mentioned the model in the US where specialist mental health trained probation staff target those with mental illness and provide them with intensive support. Do you, either Charlie or Coral, whoever's taking this question, believe this model should be considered in England and Wales, and can it be considered?
Not only do we believe it should be considered, we've been advocating for it for the last 10 years at least, Coral.
Yeah, it must be. Yeah.
I mean, in that, if you want to see people talking about how it works, go to the INCJ website, because about 6 weeks ago, one of the specialist teams working in this way in Georgia in the United States gave a presentation, and it was fantastic. It's really worth looking at in terms of the way it works. I mean, we don't have an experience of the way it works, but these people working in that service describe it incredibly well. I mean, they have a reduced caseload. They don't have the same caseload as everybody else. They take everybody in the probation service that's got a mental illness and they work with them. And not just always in terms of directly their mental health. In some services, they've got brokerage roles, they've got budgets to give people reasonable accommodation and that kind of thing. And it's always struck up, Coral and I, that is, as a really powerful model.
Yeah, I thoroughly recommend that presentation. It's a really good sort of articulation of what they do.
Thank you both. I'm also interested, I guess, another point that you reference in the evidence review is the struggle that many people have in gaining access to community mental health teams, which I'm sure many on the call experience within their daily work. And I know you referenced a sort of 2-year wait in one of the instances. In those cases where waiting lists are extensive, how would you advise sort of both probation practitioners and those in the voluntary sector working with people on probation that have mental health issues to provide adequate support in the interim, particularly referencing the point you made about how training of how to work with this population is quite low across the board?
Well, first of all, that's a really difficult question to answer, because how do you continue to confront an inadequately nationally funded mental health service that you cannot get people into? And I think, you know, there's an added dimension to this, which is that I think that when people in mental health services, professionals in mental health services, learn that people have a criminal justice type history, which they would do if they were being referred by a probation officer, I think sometimes they find that a difficult thing. They automatically associate it with violence, and they shirk away from it. I don't have any evidence to say that, but I have worked in mental health services myself, and I do know how that feeling works. I mean, I saw we had someone, assistant psychologist, in the list of people attending here, who worked in a forensic outreach team. I'd be interested in what she might say about that, but I suspect that's going on as well. I mean, ultimately, what one would like to see is that people who are, you know, working in the voluntary sector, people who are working as probation practitioners, knew something about mental illness. You know, that's what I'd like to see. But, you know, you can't say that they do. You know, I've come across some, Coral and I did a big regional training program for Midlands 10 years ago, which was a sort of train the trainer attempt. Train the trainer doesn't, but we did it. And there was one person from a probation service who was also a community psychiatric nurse, or had been before. And the difference in his approach to it, given what he knew, and the difference to the other approaches was really marked. It's just so obvious. There are training programs that exist that, if there was the will, if there was the money, could be piggybacked onto. I know, for example, you heard of independent sexual violence advisors, ISVAs. Well, they have a training program in mental health that has been developed by Limehouse. Now, that sort of product, you know, in the voluntary sector would be very useful, I suspect. But so, you know, you don't have to reinvent the wheel necessarily. But there are some important things about training that we personally would like to see included. Should we put up our last slide about what we think should be included in training?
Yeah, that would be great. I'm sure Paul can pop that up. But thank you, Charlie. once that slide's up, I will then hand over to Russell because I can see some questions coming through the chat. And as much as I'd love to continue, I will make sure that everyone gets a chance to ask.
Coral, if it comes up, you talk to it, yeah?
Sure, yeah. It's the very last slide, Paul. There we go. So this is just some suggested content that we put together. So like Charlie said, this is not a finished article, and we think actually it needs to be developed alongside service providers and clinicians, and also people with lived experience, ideally feeding into it. And some of the work that I've done recently with revolving doors, the suggestion that actually all training on this topic should involve that lived experience voice as well, as part of it. So that's something that we'd like to really see. But sort of an overall introduction to mental health, engaging with clients in crisis, DBT techniques, working with psychosis, because as we've shown, there's a high prevalence of psychosis amongst people on probation, psychoeducation for probation staff, appropriately challenging delusions, suicide awareness, given the statistics that Charlie quoted earlier, and particularly important in those first few weeks, and just mental well-being and social prescribing are our sort of suggested starting points, but it's definitely something that we'd like to explore further in the future.
Great, thank you, Coral. Russell, over to you.
Thanks very much, Emma. Thanks, Charlie and Coral. I think that was a lovely kind of tour through just how complex the issue is and how hard it is to get resources there. We've got questions in the chat, which I'm going to go to in a second. Please do put a question in if you've got something in particular you'd like to ask. Charlie and Coral, I think, are by far the most eminent researchers working in this field, and it's a real opportunity to get to speak to them direct. Can I go first to Helen Argyropoulos? I hope I haven't mangled your name too badly, Helen, to ask you a question.
Thanks. I was actually quite a good pronunciation. So I just wondered if it was worth looking into, and if it would be possible to look into what came first, like the mental health issue or the custody sentence, and then the correlation between like time in custody and how this might cause or aggravate the mental health issue. And then I was also just wondering about like what could be done preventatively to intervene earlier for those with mental health issues so they don't end up in the criminal justice system, and what, how likely that could be.
Can you tell us what you do, Helen?
So I work with a charity and we support people coming out of custody and just resettlement, but I have a background in social work as well.
Okay. Well, I think there is an attempt at the front end to divert people from the criminal justice system through the MHTRs, the ATRs, the DDRs. I know someone's asked on the messaging what those all stand for. Mental
health treatment requirement, alcohol treatment requirement, drug rehabilitation requirement, which can be handed down to the court as part of a community sentence.
Yeah, so those do exist. Throughout this whole piece, my biggest concern is for people with the psychosis and those with a serious mental illness, and largely the MHTRs to date have been used for people with moderate depression and anxiety. Go to those two references, calendar, that were in that list on the evaluation slide, not people with psychosis. That should be the case. I think there should be some diversion for people like that. Sorry, can you remind me what the second question was?
Sorry. Kind of looking into the correlation between a custody sentence
Yeah,
and having like a
yeah,
mental
yeah.
health issue.
I think there was some research that looked at that by a woman called Jenny Shaw in Manchester. She was interested to see whether if you had um, a mental illness at reception to a prison, did the
Mm.
sentence itself make those symptoms more severe? But I can't tell you what she found or whether that research ever went ahead. I just remember hearing about it.
Right.
So it might be worth Googling her and seeing if you can find something.
Thanks, I will.
It's certainly an issue, Charlie, that's talked about a lot with IPPs. So people on the indefinite sentence, some of whom have pre-existing mental illnesses, but clearly not having a date for release, not being clear what you have to do to be released. It's clear that a lot of people's mental health has kind of deteriorated, which of course means that less likely that they're recommended for release, and people are caught in a kind of vicious circle there.
Yeah, absolutely. And some of those people have committed suicide, haven't they?
Mm.
I'm afraid there is a very high rate of that. Lovely, thanks, Charlie. I think we'll move on so we can get as many questions in as possible. Michelle Vosper's got a question about Reconnect, Charlie, which I know you've got thoughts on.
Yeah.
Michelle? Are you there, Michelle?
Hi there, can you hear me now?
We can, yeah.
Yeah, I couldn't unmute myself. It wasn't letting me. Sorry about that. I was trying to type at the same time as unmuting myself. Thanks for letting me just ask the question, really. So yeah, as a regional health and justice manager, I've kind of got 4 counties, I suppose, in Yorkshire and the Humber, and I'm starting to see the Reconnect service mobilised in our region. So it was just asking kind of, whether there's any kind of link been made to, I believe there's a national team, whether there's any kind of, I don't know, plans to look at the impact. It's quite early days for us in Yorkshire and the Humber. West Yorkshire's the only area to really start showing some kind of full prison coverage and numbers, but we are seeing some good navigation. I think something I saw last week is I used to be a MAPA manager, and I think sometimes there's a benefit having a health person talk to a health person. So from a probation perspective, I sometimes, even though I felt quite confident with sort of some mental health situations, I think sometimes having that advocate from Reconnect, for example, hand holding the person, going back to secondary services, what in the example I'm thinking of, it did really help. Despite probation sort of saying they thought they needed an assessment for under the Mental Health Act, it was only when Reconnect got involved that they actually managed to do it. So yeah, I think the health to health benefit, I'm starting to see some positive sort of green shoots. But yeah, just your views really on how you think it might fit.
Michelle, would you just give like a very brief description of Reconnect for everyone just before Charlie and Coral answer that?
Yeah, sure. So it's NHS England commissioned, so it's not a commissioned probation service. It's the West Yorkshire model would be, and I think it's reflected nationally. There is some mental health practitioners based within the prisons. So we've got 3 prisons covered in West Yorkshire, male and female. They can triage an assessment that can come from a range of sources: probation, prison, healthcare, self-refer. The person needs to have a health need that might need some navigation through the gate. If we didn't pick them up pre-release, then probation could refer to Reconnect within 28 days of release. So it's like a through the gate service for a range of health needs. But what we're seeing, and what I think the intention was the primary kind of cover was going to be mental health. And we are seeing that in West Yorkshire. Substance misuse is also up there, as is kind of physical health needs, often linking into adult social care.
Thank you, Michelle.
I mean, all I would say about it so far is we don't know. There has been no wholesale evaluation, and as I indicated, as I understand it, one's only just been commissioned. I'm absolutely delighted to hear that from the way you describe it, people working in the Reconnect services are managing to get important assessments done. People by secondary mental health services. I do wonder, though, given the scarce resources that there are in mental health services, how well that will pan out, you know, in terms of a hit rate across the country.
Yeah.
It's parlous. Mental health services are in a terrible state. There's been a really interesting discussion about that by leading psychiatrists on LinkedIn over the last few days. And if my heart hadn't sunk low enough, by the time I'd finished reading all those comments, it was in my boots. So I don't know. We don't know. We don't know how that service is going to perform nationally, but I'm very glad to hear that from your perspective, it's had some successes.
And it's good to see some resource going into trying to make those links through the gate as well.
Yeah.
And what you said about kind of health to health conversation also rang true for me. Years ago, I used to work for the probation service in the senior admin role on a lottery funded project where we based nurses in probation officers so that they could assess people's health and then, you know, either give kind of brief intervention work or help people to manage their own health or help people to access community-based care. And I would say the same kind of thing happened there, that, you know, a nurse speaking to a GP alongside somebody on probation was an effective conversation, and there was maybe a different level of confidence there in that conversation than there was with probation workers. So, you know, it was quite an effective model, but lottery funded, and it's a shame that we don't have these kinds of things as sort of longer term investments really, and likewise there's still that evidence gap that we need to fill so that we can then make the argument for commission of appropriate services in the community. And I really show why we need that resource so that these teams, whatever these teams look like, do have somewhere to refer into.
What I'd add to that is that, of course, not everybody being seen by a probation practitioner has come out of prison.
Yes.
And that group often get overlooked, and we do need to evidence their needs too. And also, obviously, people's needs can change throughout their sentence as well. So, you know, even if you are released from prison, that's not to say that your needs are going to stay the same as they were when you were released. So we need to be aware of that as well, that, you know, often release can be quite a challenging time in a number of ways. People's health kind of changes over time, doesn't it? So we need to keep an eye to it throughout somebody's sentence.
I mean, we haven't talked about women in particular yet, although I have seen from the messages that some people work with women. I undertook a classic review of trauma-informed care in prison for women, and there are a number of studies that evaluated trauma care. But we concluded that we didn't think that it was a good idea. We thought that prison environments were far too triggering to undertake some sensitive therapy like trauma-informed care, and that should be available to women who are coming out of prison. But I have no idea where that service would sit, how it would be funded, and how it would work. But there should be such a service.
I guess we'd have to look to cite it in women's centres, Charlie. That would be a kind of practical first step.
Or, you know, if we followed Baroness Corsten's recommendations, it would exist now in the small-scale female facilities that were posited by her as an alternative to prison.
Michelle, thanks very much for that. And I think we were glad to hear your question, because I know Charlie, Coral, Emma and me were talking about this in our prep, and we'd mainly been told about Reconnect as a signposting service. So it's good to hear there's some actual direct face-to-face work going on as part of the service.
Yes. Yeah, no worries. Thank you, everyone.
Thanks, Michelle.
Can I move on to Stephen Brooks now? Stephen's got a question about online therapy provision, and I know this is a kind of growing area. Stephen? I can see Stephen's unmuted and he might be struggling to get through. You there, Stephen? I'm going to take the liberty of asking your question for you, Stephen. So he's asking Coral and Charlie what your thoughts are regarding online therapy sessions for those with mental health issues on probation.
That's an interesting one.
I don't mind answering that, Coral. Well, I think given the practical difficulties there can be, even something simple as attending an appointment for a client on probation, they're probably a good idea. But I don't think we know. I haven't seen any published evaluations of that kind of therapy. Does Stephen know any different? Are there studies that have looked at that?
I'm not sure there's studies, Charlie. I know it's a growing area for people on diversion activities, police diversion activities, a range of accredited online CBT kind of programs. So I think they have internal feedback, but I'm not aware of any kind of, well, certainly not in this country of any evaluation. But your gut thoughts about whether it might be worth an area to explore?
Well, maybe, but you know, again, it's playing to an audience who are likely to have depression and anxiety. And my concern is the group that are always ignored are people with a psychosis.
I'd also say we need to consider how people can access that sort of care as well, because not everybody on probation is going to have access to digital technology or understand how to use it properly. You know, certainly study that I did around probation's health related role during COVID, that was one of the themes that came out of that study. You know, that especially for people that have been imprisoned for a long time, that knowledge is not always there. So, you know, something like making an appointment with a GP online can be something that people struggle with, you know, and so I can imagine that potentially being an issue for online therapy. So, you know, there might need to be some support in place there to either give people access to the technology or support people to be able to use it properly to get the most out of that.
Thanks, Coral. I'm going to move on just to give as many people the chance to ask questions as possible. Rhiannon Lovell has got a question around foreign national offenders' experiences on probation. Rhiannon, I'm hoping you're going to be able to unmute yourself and ask a question. We shall see.
Can you hear me?
Yes.
Yep. Oh, great. Okay, good. So we work with foreign nationals in specifically HMP Huntercombe, and we're aware that anecdotally there's a lot of anxiety about the uncertainty of processes and about people who don't know when things are happening, and a lot of experiences of self-harm and that kind of thing. But I'm not aware of a lot of research to quantify that. I'm just interested to know whether you guys have any experience or research that that we could review to kind of to quantify the experiences of our clients a bit.
And that's specifically around people wondering if they're going to be deported, and if so, when. And
that's the biggest uncertainty. Often people aren't able to work because of their immigration bail conditions whilst the deportation proceedings are going on. So there's a lot of uncertainty and inability to support yourself, and no real timescales on anything.
Thank you.
I have to say, I personally, I have to declare I don't know anything about this at all. Coral, do you?
No, I don't think I've ever read anything on that topic, in all honesty. I can see that it's an important one, especially in today's climate, but I don't think I've ever seen a paper about that.
I've often thought, though, that and I don't know whether this pertains to your question, I've often thought that the mental health needs in immigration removal centres must be really
yes. yeah, and they are, and we have colleagues in other organisations who support in that particular environment, and yeah, the needs are very high. But
Yeah.
Interested from the prison point of view, because often these are people who have made their lives here and yet don't have a British passport, and so are being considered for deportation to a country they might not know. So there's a whole nother ball game of anxiety there.
I bet.
Yeah.
Okay.
Well,
thanks anyway.
That's one for my agenda. Thank you.
Definitely.
Yeah, excellent. Always happy to chat. So do get in touch.
Okay.
Thanks, Rhiannon. And of course, we know there's a lot of kind of government noise and discussions about increasing the number of foreign national offenders being deported. So I'm sure that's going to be a very increasingly topical subject. Thank you ever so much, everyone, for asking your question. The slides will go out with the kind of communications after the session, but I'm going to hand back to Emma now.
Great. Thanks so much, Russell. And yeah, a massive thank you. The hour has flown by. We are approaching the end of the event, but a huge thank you to Charlie and to Coral, Russell as well for leading that Q&A, and to Paul for all the behind the scenes work going on for this event. And thank you all for those of you that have joined, engaged with the conversation. I can see lots of comments in the chat that we'll be kind of reading through afterwards and following up on, and making sure that everybody has made the most out of today. And as Russell said, we'll be able to share the recording of this video. It will go online on our evidence library on our website, so that you can sort of watch back and share with any colleagues or anybody else you think would find this conversation useful. And we'll also make sure that the slides that Coral and Charlie went through are shared as part of our post-event email resource, so you can have a look at them in your own time. Paul is going to pop a link in the chat for a bit of our feedback evaluation form. So we'd really appreciate people taking a couple of minutes to just fill out your questions and fill out the answers, and let us know how you found the event today. And also just to let you know that this, obviously, as I explained at the beginning, is a series of evidence library events, and we've just popped on the next one, which is going to be with the Chief Executive of Prisoners Education Trust, John Collins, looking at the latest evidence and key elements of what makes for good prison education, and that will be on Tuesday, the 23rd of April at 2 p.m. So you can book onto that now. And again, I think Paul will pop a link into the chat if anybody's interested in booking onto that, as well as any other events that we've got going on at Clinks. But otherwise, thank you so much again for joining us, and we hope to see you at a Clinks event soon. Thanks all.
Thank you.
Thank you. Bye.